Now, a special report on Advanced Directives, Part 2 in our series on the problems of end-of-life medical care. Too often, elderly patients become unable to say what kind of care they want, and doctors and families are left to decide that by themselves. But at the Gundersen Lutheran Medical Center in La Crosse, Wisconsin, elderly patients are encouraged to make choices about their future care and sign advanced directives so everyone knows their wishes. Lucky Severson reports.
Who or what helps you when you face serious challenges in your life?
Well, I always get comfort from Audrey, my wife.
Of 61 years?
Yes, of 61 years, yes. As of last Friday, so.
That's right.
And then our pastors. Yeah.
So your faith is important.
Yeah, the faith. Oh, yes, very important.
Conversations like this at Gundersen Lutheran Hospital in La Crosse, Wisconsin, are what set off the nationwide outcry over the so-called death panels. This is Curtis Nelson, connected to a dialysis machine with his wife Audrey and his son Dennis. Teresa Clements, a nurse, is guiding the discussion.
With your particular illnesses, and you've got the multiple myeloma, the heart failure, and now the kidney disease, it's difficult to predict when a complication could occur.
Yep.
And then it could happen suddenly, and you might be unaware, unable to make those decisions.
These end-of-life conversations began in the 1980s at the urging of the hospital's medical ethicist, Bernard Hammes. He had grown alarmed after listening to staff doctors distressed about how to treat incapacitated, terminally ill patients.
What does the patient want me to do? The patient now was too sick to ask. The family, when we asked the family, had no idea what the patient would or would not want. And so we were really faced with this moral or ethical dilemma.
And when the doctors don't know what the patient or the family wants, Hammes says there's only one thing to do.
Here and anywhere in the world, quite honestly, when you have a patient coming into a hospital who is very ill, maybe dying if we don't treat them, our assumption is that treating and attempting to prolong life is the right thing to do. And that indeed, from an ethical, professional perspective, is the right thing to do. But is it what the patient would want?
You have a serious complication from your kidney disease. You have a good chance of living through it, but you're not going to be able to either walk or talk or both, and you're going to require 24-hour nursing care. You would choose the following: to continue all treatment, because living as long as possible is the most important. You'd stop all efforts, including dialysis, to keep you alive because your quality of life is more important than your quantity, or you're not sure.
That would be terrible to have to. I wouldn't want to have that.
So to stop all efforts then?
Yeah, if you got into a position like that, yes.
In La Crosse, Wisconsin, 96% of the patients who die have gone through these advanced directive discussions and designated how they would prefer to spend their last days.
This program is not trying to talk people out of treatment. This program is trying to help patients make informed decisions so that we know what they would want, even in a crisis, and we can deliver the services that matches their preferences.
The program has been so successful, representatives from around the country now attend seminars at Gundersen Lutheran. The success is due in part to the backing of the Catholic and Lutheran churches. A similar program is underway in Minneapolis-St. Paul, which is supported by the head of the National Association of Evangelicals, Pastor Leith Anderson of the Wooddale Church outside Minneapolis. He says he witnessed too many families going through emotional turmoil when their loved one was dying.
For the family, that there are processes in place is wonderfully helpful, because often children and spouses, they're frightened. They don't want to make a mistake. They don't want to give up too soon. They don't want to hold on too long. And if it's been discussed, and especially if it's been documented in writing, that is really a gift to family.
Pastor Anderson says both he and his wife have filled out advanced directives, and he's encouraged members of his congregation to do the same. The directives, he says, are biblically based, and he uses as an example the story of Jacob when he knows he is about to die.
And it tells about him bringing all of his sons around him. And he gave a prepared statement to every one of them. And it was different for each one. But the Bible line in Genesis 49 says that he gave instructions. Now, that's marvelous. Here long ago was a man who knew he was going to die and gave final instructions.
Advanced directives today detail individual treatment, assign power of attorney, and are available electronically. Hammes says they are not death panels, a description he says is simply a lie. He says some people choose to stay alive with any technology medical science can offer. A majority request less invasive treatments. Some, because of their religious views, are ready to meet their maker.
If those hopes don't come true, what else would you hope for, Curtis?
No. If the Lord says I can come in.
That the Lord says you can come in?
Yeah.
The hospital now trains social workers, nurses, and pastors to conduct these discussions. Bernard Hammes has filled out his own.
I'm not making a judgment for you or for anyone else. But I think we live in a world in which we have to share resources. That's a spiritual value for me. So if I receive medical care and it reaches a certain stage and it's not going to change the outcome for me, but a lot more money could be spent, I would say, you know, the cost of this care has reached a point that I no longer feel is ethical because other people don't even have basic needs being met.
Although it wasn't the original intent of Gundersen's advanced healthcare planning program, there has been an additional benefit. It saves money. Typically, hospital costs for a patient's last 6 months of life nationwide average about $31,500. At some hospitals, it's twice that amount or more. At Gundersen Lutheran, it's $22,000 because the patient spends fewer days in the hospital.
Where would you rather spend your time if you had 2 years to live? In the hospital, going through tests and procedures? We're putting many, many patients in this country through a lot of additional suffering and expense, some of which they're going to have to pay for. It's the fourth most frequent reason for families to go bankrupt.
There's another reason hospital costs are less. Doctors here are paid a salary. Dr. Jeff Thompson is CEO of the Gundersen Lutheran Health System.
In our organization and others like us, a physician gets no extra money because they do a CT scan or a lab work. There's no added incentive to put patient in the hospital.
Dr. Greg Thompson, a pulmonary critical care specialist, says these days the intensive care ward mostly treats patients who have a better chance of long-term survival.
Many of those patients who have the underlying terminal disease don't even come to the intensive care unit because they have already decided that at this point in their life, that's not the level of care that they want. They want care, but not the critical care that they would receive in a critical care unit.
I think that there's a growing number of people who do not want to have a lot of tubes connected to them. I would say that increasingly I am hearing people say, I want to die at home. So they're making a choice that dignity is more important than more days.
Any other hopes for you that you guys?
Oh, I would hope that he'd get off of this, you know, and that if it is eventually going to happen, that it wouldn't be a long, drawn-out process in passing. So.
Yeah, that's the biggest thing. I don't want to, you know, if it's going to go that way and that, I don't want to have it dragged out.
Mm-hmm. So this is a good conversation to have, then.
Yeah. Yeah.
In these discussions, talk is about practical things, but often turns deeply personal.
People don't like talking about death. It's a taboo in our society. This is a very intimate conversation. When you talk about these issues, you're really talking, if you will, about the meaning of life, about your religious beliefs and faith, and ultimately about who you are. And that's a little frightening to most of us.
So they worked really close.
At the end of these discussions, Hammes says he often hears the same thing from the nurses and facilitators who conduct them.
What they will report to me is that what they experienced was a sacred space. What happens in families when they really get into the meaning of this conversation is they tell each other how important they are to each other.
The idea of advanced directives appears to be gaining traction. Intimate discussions about the end of life are now starting to take place in hospitals around the country. For Religion and Ethics News Weekly, I'm Lucky Severson in La Crosse, Wisconsin.